We are very honored to have Dr. Vince DiNapoli join us. Dr. DiNapoli is the director of the Brain Tumor Center at the Jewish Hospital Mercy Health and director of the Brain Tumor Center for Excellence at Mayfield. He is also a board member of our Mayfield Foundation. Dr. DiNapoli has particular expertise in open neurosurgery and endoscopic skull-base surgery for malignant and benign disease, including primary and metastatic brain tumors, pituitary tumors, and a minimally invasive spine surgery. He was recently named one of Cincinnati's best doctors by Cincinnati Magazine. Thank you for being here, Dr. DiNapoli. You may now begin your presentation.
Thanks, Deb. Thanks everybody for joining us this evening, spending some time with us to learn about brain tumors and the most recent developments and how we treat these patients. As Deb said, I joined Mayfield in 2015. I did my residency here with Mayfield from 2008 till 2014 and did a year down in Houston, Texas, specializing in neuro-oncology and skull-base surgery at MD Anderson Cancer Center. So tonight, we're going to cover an overview of the types of brain tumors, just generally, causes and symptoms, things to look out for. Then we're going to go through some of the more recent advances in treatment options. And then at the end, we'll cover some specific, more recent developments in biomarkers and genomics that help us subtype these patients. And hopefully in the future will lead to advances in how we think about and treat these patients going forward. So generally speaking, when we think about the types of tissue inside the head, we have the skin and the skull. Directly beneath the skull, layering the inside of the calvarium, we have the meninges, which is basically a protective sac around our brain. It's like a leathery, thick membrane. Inside the meninges is the spinal fluid, and then the brain tissue itself. That's composed of neurons, which actually make the things happen, and then the glial cells, which are the support cells that actually support the neurons. At the base of the brain, within the skull base, we have a gland called the pituitary gland. That's the master hormone gland in our body, responsible for things like cortisol, growth hormone, prolactin, and other types of hormones that regulate our bodily functions. And then there are nerves, obviously, that come out of this brainstem in the posterior fossa compartment of our brain that are responsible for a lot of other critical functions like moving our eyes, our ability to swallow, and many other things. Within the brain matter itself, when we look at it at a closer level, like I said, there are neurons. Those are the electrical cells that actually send signals down into our brainstem and into the spinal cord and make our muscles move and all the other amazing things that our brain is responsible for. Supporting the neurons are the glial cells. The glial cells kind of keep the environment safe for the neurons so that they can exist and function the way that they're supposed to function. There is also something called a blood-brain barrier, which is important when we treat brain tumors because this is a kind of a wall between our circulatory system and the brain itself. We don't want contaminants or toxins getting into the brain and causing, excuse me, death of neurons, because neurons are not really replaceable. So the brain has a very strict barrier between what goes through our bloodstream and the brain matter itself. And that's important with delivery of chemotherapeutic agents, trying to get those agents into the brain so they actually can affect the tumor that we're trying to treat. When we think about brain tumors, we do think about them in two broad categories, sort of benign and malignant. Benign tumors include things like meningiomas. Those come from that covering around the outside of the brain that we were talking about earlier. Those always tend to be pretty benign. They grow slowly, usually less than a couple millimeters per year. These are one of the most common tumors found inside the head when we do a scan, and oftentimes they're found, after a patient that suffers a car accident or has a head trauma or even just gets scanned because they have a headache. We see these tumors sitting in there, and oftentimes they're asymptomatic, and we end up watching them. If they're large or creating pressure on the brain or causing other, the thing that causes these tumors to become symptomatic is they create mass effect and push on things that are around them, and oftentimes that's what leads to treatment. Pituitary tumors come from that gland we talked about that controls all the hormones. These tumors are also benign, and oftentimes, again, if we find them and they're small, we end up just watching them and observing the patient with MRIs each year. If they start to grow, or if the tumor itself starts to secrete hormones that are outside the control of the normal body regulation, then oftentimes those tumors will need to be treated with surgery, radiation, or medications. And then lastly, at the bottom of the screen there on the left, you see the neuroma. Those are tumors that arise from the nerves themselves. One of the more common types of these types of tumors is an acoustic neuroma or vestibular schwannoma. That's the same tumor. And that arises from most commonly the balance nerve, the vestibular nerve, and is around the brainstem, and creates mass effect and oftentimes needs to be removed. The most common symptom with that is loss of hearing. So this slide outlines the more malignant tumors. The most common tumor that you hear about in this category, and certainly has been featured in the news with people like Senator McCain and Senator Kennedy, is something called a glioma. So these tumors come from those support cells in the brain that we were talking about. These are oftentimes in adults, when they start, they can be fairly aggressive and malignant tumors. And the reason that they're so difficult is because these glial cells are insinuated into the brain matter themselves, itself. So when we try to remove them surgically, they're in and amongst the neurons, and the neurons are what actually cause the brain to function. So we can't go inadvertently removing large areas around these tumors, or else we'll start to remove neurologic function. And we also know that even if we remove everything we can see on the MRI in these tumors with the contrast that we give our patients, that there are cells in the brain left behind that always need to be treated. So that's why they become very difficult tumors to eradicate. These tumors are graded, usually grade 1 through 4. Grade 1s are uncommon in adults. Those are mostly in children. Grade 2 through 4. Grade 2 is what we usually refer to as low-grade glioma. So within glioma, we usually say high-grade or low-grade glioma. Low-grade is specifically really just grade 2. And then high-grade glioma includes grade 3 and grade 4, with grade 4 being what people call GBM or glioblastoma. That's the one you heard about in the news with Senator Kennedy. And then a third broad category of tumors inside the brain are tumors that come from elsewhere. So this is also very common, the most common type of tumor we see in the brain outside of the primary tumors. And these are cancers that are existing elsewhere in the body, like lung, breast, melanoma, skin cancer, that travel from those locations into the brain. The most common type of that is lung cancer. So these are the types of tumors that we just kind of quickly outlined. Those are the order of how common they are. But in addition to those 3 types that we kind of just briefly outlined, there are many other types of tumors that occur inside of the brain, in and around the central nervous system, that obviously too extensive to detail in our talk tonight, but it encompasses quite a large range of tumors that can affect anything from the brain all the way down through the spinal cord and the peripheral nerves that go out into our extremities. So the risk and causes of brain tumor, this is a common question I get in the clinic when people are facing these diagnoses, what caused this? And unfortunately, in many cases, we don't have a great answer to that question. We know there are certain genetic mutations that can lead to these tumors occurring, but in the vast majority of people, we refer to these as spontaneous, meaning that there's no family history, they haven't had any specific exposure or risk factor that should place them at risk for these tumors, and it's just a spontaneous mutation in these cells that causes these tumors to grow. There are some known risk factors, things like chemical exposure, exposure to repeated ionizing radiation, like if someone has had repeated CT scans, especially when they were a child, or X-rays, someone that was exposed to some kind of a nuclear disaster, things. Those populations definitely develop brain tumors more with a higher prevalence than the general population. Other things have been looked into, like poor diet, high in cure meats, or other things that have been known to contribute to other types of body cancer can definitely play a role. Smoking, the cell phone theory has mostly been debunked at this point. Family genetics, most of these tumors, like I said, are not genetic, but there are a couple of syndromic things that can happen that do lead to brain tumors. But most of the time, those syndromes are recognized fairly early in life. So that's not the most common way that people develop these problems. When someone develops a brain tumor, the most common headaches are listed here, or most common symptoms are listed here. Headache being by far probably the most common, followed closely by seizure. So someone just develops a headache, this is usually someone that isn't usually having headaches all the time, or their normal headaches become more severe and they become progressive over time. So getting worse by the day or by the week. Seizures, people can have seizures where they develop weakness or numbness in their arm that then progresses even to a generalized tonic-clonic seizure. And then other less common things are all the things that are listed here. And it really depends on the area of the brain that that the tumor is arising from. So that gives us a strong clue as to where we should be looking. Some areas like the primary motor and sensory strip, those things are very, you know, stereotypical for where the tumor is. If something has a problem with a motor strip, the opposite side of the body, they have paralysis, right, or they have loss of sensation. Those things are readily recognizable. But some of the tumors in the frontal lobe or the temporal lobe, these areas can be more cognitive areas, things that are less specific. So people can oftentimes have tumors in those locations getting very large before they have symptoms, or at least recognize those symptoms, as people chalk them up to, I'm tired, I'm stressed, or they're going through something in their life that they just kind of say, oh, this isn't something I need to pay attention to. And by the time we actually find the tumor, it's pretty large. So going through some of the treatments that we use for these conditions, as I said, with a lot of the benign tumors, observation can be an option. Things like meningiomas, acoustic neuromas, when we first diagnose them, pituitary tumors, these tumors can oftentimes be observed if they're small or if they're not creating symptoms. And that is really the best treatment for those patients, and can usually be done for many years before the patient requires something to be done. Surgery oftentimes will involve a craniotomy, where we make a window in the skull, go in and take the tumor out. We also employ a lot of skull-based techniques and minimally invasive techniques that we go through the nose. We work with our ENT colleagues to accomplish those approaches. And so we've been able to become more sophisticated and more targeted over time, so that we're not disrupting normal brain tissue when we go in to take these tumors out. We're trying to develop pathways into the tumor where we go through normal planes of anatomy, or take away bone around the brain rather than move the brain aside, in order to create a pathway to get in there, take the tumor out, and then get out without causing, collateral damage, essentially. Another big development in neuro-oncology over the past 15, 20 years has been the field of radiation oncology. The technology has become far more sophisticated, allowing us to outline and really specifically target these tumors. We get MRIs, we are able to basically outline that tumor on the MRI, place the patient in a complex robot, which then delivers that radiation and specifically outlines the tumor, almost paints the tumor with the radiation, so that you're not hurting the adjacent brain or other structures, and be really able to deliver a pretty high dose to the tumor and hopefully kill it or slow it down. And then lastly, we work with our neuro-oncology and medical oncology partners to give chemotherapy to the patient, and that just really depends on the type of diagnosis and what we're treating. That can be done either usually through the IV, or some of the most common chemotherapy for gliomas is actually done in a pill form. We sometimes even put that chemotherapy into the tumor resection cavity, although that's become less common. So the surgery goals, when we think about surgery, obviously one of the big goals of surgery is to obtain a diagnosis. When we're looking at an MRI, as much as we can guess and postulate what that tumor might be, we don't know for sure until we get in there and get a piece of it out and send it to pathology and they tell us what it is. Obviously the next highest goal on the list is to remove as much of that tumor as possible. If we're taking that patient to the OR, putting them through the risk of surgery, we want to design an approach and take the time to get as much of that tumor, if not all of it, removed, especially in benign cases with things like meningiomas or vestibular schwannomas. If we can get that tumor out, you have a potential for a cure for that patient. And some of the more malignant tumors like gliomas, our goal is to remove all that area that lights up on the MRI, that contrast enhancement. But we know going in there, the idea of taking all of that tumor out is really not feasible, because that tumor has insinuated itself in the brain many centimeters away from the primary site. And if we go chasing all that tumor, we're going to cause a lot of collateral damage. So that's the next point there, is we want to avoid loss of brain function. We do a lot of things to, as we said, to design these surgical approaches so that we can avoid damaging parts of the brain that are going to cause that patient neurologic deficits and hurt their quality of life. So sometimes if the tumor is deeply situated in the brain, or if we just want to get an answer before we go in for a full surgery and to try to take the tumor out, we opt for something called a biopsy. So this is done oftentimes with a small window. So we just make a small incision, a little dime or nickel shaped opening in the bone. And then we use a needle that we advance using stereotactic guidance. So that's like a GPS system for the brain. We guide that needle down into the tumor. We open up a little window, and we take a piece of the tumor and we pull it out and we send that to pathology. And then we wait in the OR while the pathologist tells us that we got something that is meaningful, and we close up, and then we get final pathology results about 10 days later. This can be important, like I said, especially for deep-seated lesions that we can't go in and take out necessarily, because we want to get that diagnosis. We also, for things like glioblastoma and other more malignant tumors, we want to make sure we're treating the right tumor, because these treatments the type of treatment varies greatly between what type of tumor you have. So you want to be confident in what you're treating. And then also some of the gliomas have certain subtypes that are relevant to prognosis and other types of treatment. So when we say craniotomy, when we talk to our patients about that in the clinic, what that really means is we're just making a window in the bone. That can vary from something like a burr hole, which is really just a small, like I said, nickel or dime size hole to get in to access the brain. Keyhole usually means more of like an expanded burr hole approach, where you're using a window, but it's very small, and we sometimes use that with endoscopes or more minimally invasive microscopic approaches where we're not making a big opening. Standard craniotomy would just be some of the bigger, where it's right under frontal or where it says temporal parietal there. Those are larger openings where we're taking out a bigger tumor. We need more exposure around the base of a meningioma. And then skull-based approaches really refer to the more complex approaches around the base of the skull, where we have to remove bone that through which maybe some cranial nerves are traveling, or potentially arteries that supply the brain with blood, all travel through windows in the base or holes in the base of the skull. And we have to open up those windows in order to get the tumor out without damaging the normal tissue. A big advancement in this in the last 20 years has been the development of image-guided surgery. So what this is, like I said earlier, is basically a GPS system for the brain. As you can see in the picture there, there's a computer system which is attached to an array. That array is fed into the camera there, that you see right above that gentleman's feet there, the two black things with the yellow in between. It reads where you are in space, and that MRI is loaded into the machine. So when we use the pointer that the doctor there is holding in his hand, we can point to the skull, and it shows us inside the head where that tumor is located. That helps a lot with localization of the incision. So as we're planning our incision, we can be more specific. We can make smaller incisions, so we're not having to basically do exploratory surgery. We know exactly when we open up that the tumor is going to be sitting right there. As we get deeper into the brain itself, then also it's very helpful in guiding us as we go into the brain, not getting off track with where we want to go very specifically, because obviously, you don't want to go into areas of the brain you don't have to be in. So the surgical steps involve basically positioning the patient, marking an incision. We then open the skin and make the craniotomy that we talked about, the window of the bone. As we said, we use stereotactic guidance often to guide that incisional preparation. We open the dura, expose the brain. We go remove the tumor. In skull-based surgeries, that opening and exposure portion of the procedure can be a very long portion of the procedure. So a lot of that drilling of the bone, especially for things like vestibular schwannoma, we spend 2-3 hours with our ENT colleagues drilling away bone so that we don't have to then displace brain in order to remove those acoustic neuromas safely and do as little damage as possible. When we're done removing the tumor, we close the dura, replace the bone, and then close the skin. So this is an example of how a patient might be positioned in surgery for a tumor. In this case, looks like the left parietal area. As you can see on the right there, the patient is positioned in a Mayfield headrest. So that's a clamp that we use. Our patients are, educated about that prior to surgery. But it's the reason we use such a device. It seems a little medieval, but we want that patient's head completely immobilized during surgery. It's important for several reasons. One is we're using that GPS system, and if the head of the patient is moving, then the relationship of the patient's head to the frame that's telling us where the tumor is in 3D space is going to change, right? So that through that GPS system is not going to be accurate. The other reason is as we're operating, especially deep in the brain around cranial nerves or around blood vessels, we don't want the patient moving or shifting in surgery, because differences of millimeters in neurosurgery can have very severe consequences. So this is just an example of a typical window we might use. This is something called a terional craniotomy. So how we do that is we make that skin incision, we make a little burr hole there right behind the eye, above the eye. We do that with a drill. We then use the drill with a different attachment to cut a very thin line in the bone around to make an actual circular shaped piece of bone that we can then elevate and take off the dura. So underneath of the dura, there, or underneath of the bone there, the bone's been removed, you see the dura. The dura, like we talked about earlier, is a thick leathery membrane. It's also called the meninges. That's why we call those types of tumors meningiomas, because they come from the dura. As we're opening the dura there, underneath of the dura, you're going to see the surface of the actual brain. So there's a short, quick video here just kind of showing us as we do that. You see the skin's been open there. The edges of the craniotomy there, kind of down by the inferior, by the surgeon's hand there. Now we've opened the dura and flapped that open, and you can see the circular dura opening, and then underneath of that, the surface of the brain. Those dark blue vessels running on the brain are veins, large veins. We then coagulate the surface of the brain and open the surface of the brain so that we can get into it to remove the tumor from within. So it's just getting into the brain itself there. And as we're getting in there, we see the surface of the tumor. You can see we're rolling the tumor around there. It's underneath there. It's kind of he's pushing it, we're pushing it around. Just working our way around the periphery of the circumference of the tumor so that it can be lifted and removed from within the brain. And then you can see the tumor itself there is in the center of that picture, and it'll be lifted clean and taken out. When we're done taking out the tumor, like we talked about earlier, we go ahead and stitch shut that dura. So the dura gets closed watertight all the way around the circumference of the opening that we made. So we do that with a suture. We don't want the spinal fluid leaking out after surgery, or just kind of showing how we do that. And then when we're done stitching the dura shut, we replace that flap of bone that we removed at the beginning of the surgery. We usually reattach that with a couple of titanium plates and screws, which rigidly affixes it to the patient's skull. Then when we're done with the bone, we close the skin there. The skin's been closed with some staples and apply our dressing. This is a picture on the left here. That's an MRI that is demonstrating what you might see preoperatively. So what you're looking at there is a cross section of the patient's head. So the gray in the center of the skull there, or in the center of the picture, is the patient's brain. That bright white around the periphery is the skin, and just underneath that is the skull. That bright tumor, I don't know if you can see my cursor there, but this bright tumor back here in the back right part of this picture is the tumor itself. So that bright white enhancement is the patient's undergone an MRI and they've given him IV contrast, and that contrast leaks through the blood-brain barrier and shows that tumor lighting up bright white, and that's an abnormal finding. You can also see that darkness around the bright white spot is swelling, or what we call edema in the brain. So after our surgery here, you can see down in this bottom right part of the picture here, there's been a flap that's been created. You can see where the cuts are in the bone. And directly under the bone, you see some real dark black spots. That's air in the brain where the tumor has been removed. Usually for these types of surgeries, this looks like probably a metastasis case. These patients would stay in the hospital 2 to 3 days, and that's a pretty average stay for most of our brain tumor patients. Usually getting back to within 2 to 4 or 2 to 6 weeks, just depending on what we've done. If they have other problems going on, they might sometimes go to rehab for a period of time. And then, we expect a full return to work, driving, full activity, all those things within about 6 weeks. And that obviously usually depends on the diagnosis and what's going on, but especially for benign tumors, our patients can return to their normal life pretty quickly. Potential complications of surgery that we always discuss with our patients. If the patient's had a seizure before surgery, they might come on seizure medications before we meet them, but we do usually put them on anti-seizure medications during the perioperative period for at least a week after surgery to prevent any seizures that might arise from us just, causing inflammation in the brain from surgery. Infection is something we worry about, deep vein thrombosis in the legs that could lead to pulmonary embolism or something is also something that we try to thwart off as much as possible. And then as we talked about neurologic deficits, we have to design a surgery that's going to allow us to remove the entire tumor, but also leave the patient normal after the operation. Other adjuvant treatments that we use in conjugation with surgery would include, so this is stuff that we do in the operating room while we're operating, would be chemotherapy wafers or radiation seeds. The chemotherapy wafers have really become not as effective as we might have hoped they would have been, so that's not been used much recently, but we are one of the centers that is leading the charge in the development of a new type of radiation seed called the gamma tile therapy. So we've been doing what we call brachytherapy in the brain for several years. What this involves is placing seeds in the cavity after we take the tumor out. So we remove the tumor, you have a cavity sitting there that we worry. So for malignant tumors like lung cancer or say a GBM that's been already failed primary therapy, we can go in, excuse me, remove the tumor and then leave these seeds around the periphery of the resection cavity in order to kill those cells that might be left behind. The gamma tile has been a big advancement because what they've done is they've implanted those seeds into reabsorbable sponges that can really facilitate the placement of the seeds. Instead of placing individual seeds and trying to glue them in place and keep them in place, this allows us to place these patties around that cavity in a very, geographically, the spacing is very even. So we can do that quickly. We don't have to worry about those seeds moving and deliver it very effectively. And we can do that in less than 5 minutes. Mayfield doctors were actually the first in the country to do this for metastatic disease and one of the first in the country to do this for patients with recurrent GBM. So we're excited that this could offer some hope for these patients. So other things we do, and this is more in the planning preparation of surgery. Functional MRI is a very cool technique that we use to localize areas of the brain that are responsible for specific functions. So when if we have a tumor that's sitting right next to someone's presumed speech area, we can put that patient into an MRI and give them special tests while they're doing their MRI. And those areas will actually light up on their MRI scan. So we can use that in planning. We can load that into our GPS system. And so then in surgery, when we're operating, we can actually point to areas of the brain, and this will show us exactly where someone's speech is or where someone's motor function is. And that really gives us a lot of confidence that we can remove those tumors effectively and really get all of the tumor out without causing them problems. This is kind of an example there of what that might look like. So on the right-hand side, this is a kind of a sagittal view of the brain. The front of the brain is at the top, the back of the brain is at the bottom. And those kind of globular colored shaped things that you see in there, those are the pink or the reddish pink there, that's the tumor. And then all those other colors that you see dotted around that area are responsible for the patient's ability to speak, the patient's ability to move their hand or their foot. So the purple area in the front left there, that's Broca's area, that's a speech area, as is the yellow area. We want to make sure we're preserving the patient's ability to understand and to use their language. And then also the motor function is sitting right there in front of it. So that gives us an idea of how to plan our approach into the brain as we go in to make sure that we're not disrupting those areas in surgery. And we have all this information available to us in the OR as we're pointing to the brain, so we know exactly where they are. We can use that in conjugation with awake craniotomy, so that sometimes we, in patients, especially with speech territory lesions, we have those patients awake while we're removing the tumor so that they're talking to us the entire time while we're taking the tumor out. And that gives us a lot of confidence that we're not giving them problems, because there's not a good way to test electrically someone's ability to speak. We can check for motor function, we can check for sensory function electrically while the patient's completely asleep. But someone's ability to talk, we can't really test unless they're actually awake and talking to us, though. We sometimes employ the awake craniotomy for that. This is another type of imaging looking at the corticospinal tracts, which is also, I think, just cool to look at there. On the left-hand side, you see the tumor, that bright white area with the black in the center of it. It's outlined in red. And then you see those purple tracts running towards the front of the tumor there. So the primary motor area is actually that green area just above the tumor up in this location here. And then those tracts are actually the wires that connect that primary motor area down into the brain and through the brainstem into the spinal cord and then out to the muscles, right? So that you can see this tumor is sitting and pushing those fibers forward, and we know exactly where they are. So when we're taking that tumor out, we know that when we get to the front part of this tumor, we have to stimulate those tracts electrically and be very careful not to disrupt them as we're removing all that enhancement that's sitting right above it, right in front of it. And this is kind of an example intraoperatively of what that might look like, kind of outlining all the tracks and things we're using, the objects in surgery that we're using to plan as we're going into the brain and taking those out. And we also can stimulate the surface of the brain with an electrical probe, and that also allows us in surgery to really be sure, if I touch this area of the brain and the hand moves, I know for sure that this is the area of the brain that is responsible for the motor movement of the hand. As I kind of alluded to earlier, in skull-based surgery, we employed a lot of minimally invasive techniques, especially using endoscopes over the past 10 to 15 years for tumors that are in and around the anterior skull base. So this is approaches we do in conjugation with our ENT partners who are specially trained otolaryngologists that can open up windows through the sinuses in the nose and above the nose to get into that area right beneath our brain. And that allows us access to things like the pituitary gland or the anterior skull base for meningiomas to remove these tumors without even making an external incision. So we use scopes through the nose, opening up corridors and pathways into those areas. It's most commonly used for pituitary tumors. And it really allows the patient to go home within a couple of days of surgery, which has been great for the patients. It also is a superior way to look into those areas because we have the scope sitting just a few millimeters from where the tumor is located rather than trying to look from outside all the way in, which is a very long distance to try to look and visualize what's going on. Another recent advancement in the surgery for gliomas has been 5-ALA. So this is a fluorescein guided surgery. So what we do is we give this drug, which is called 5-ALA, which is a fluorescent marker that actually attaches itself essentially to these glioma cells. And then in surgery, we can apply a specific filter on our microscope that delivers a blue ultraviolet light that allows these cells to light up, essentially, allows them to fluoresce. So while we're taking out these tumors, we can see on the right there, if you see that bright pink area, when you look at it on the left here where the aerial is, you just see brain, and the brain looks pretty normal, right? You don't see anything there. You wouldn't know that that was any different from any other area of the brain, but when you turn on the filter, you can see this bright pink, and that really gives us a great ability to be aggressive and remove that tumor, knowing that is specifically where the tumor is located. And especially when you're looking at the end of the surgery, you just might have a real small piece of tumor left there and you can't really distinguish it from a normal brain. You turn the filter on, you see obviously that this is something that needs to be removed. Another more recent advancement in the treatment of gliomas, specifically GBM, has been these tumor treating fields. This is something called optune, something that people may have read about. What it is it just passes electrical fields through the brain to disrupt that the tumor cell division. So our cells in our brain typically aren't undergoing cell division that much. Most neuronal cells are what they call terminal cells, meaning they divide and then they stay there through most of your lifetime. They don't make new cells like our skin cells are constantly sloughing off and we're making new skin cells. In the brain, that really doesn't happen that much. But tumor cells, obviously, because they're growing and forming a tumor, they divide pretty frequently. They go through that mitotic process with a lot of frequency. So the thought was, can we use electrical currents to disrupt that process of cell division so that the tumors then slows that tumor's ability to then make more tumor cells? And the randomized control trial that they did with this device actually did show a statistically significant benefit for those patients, although it was somewhat modest. It was about an increase in 3 to 4 months of survival. It's a very interesting finding, though. Something else we mentioned earlier, radiation therapy. So there's been a large boom or development of radiation therapy and with relation to CNS disease, both benign and malignant. And that's basically just been due to an advancement of technology over the past 20 years. So these pictures that you see here are just pictures of essentially advanced robots that use sources of radiation and then image-guided targeting in order to deliver radiation into the brain to a very specific area in order to treat tumors. So how that generally works is that the radiation beams move around the patient's head, in accordance with the MRI guidance or the image guidance. to pass beams through the head, and those beams then intersect or cross at a very specific location within the head. So the individual beam itself isn't doing any or much damage as it passes through, but when you cross all those beams in one place, it's like a magnifying glass, right? You cross 200 beams in one location, and then the additive effect of the radiation at that site is very high, right? So that allows us to essentially move that little pinpoint inside the patient's head around as the patient moves around on the table, and that dose of high beam radiation gets moved through the tumor as the patient's being moved on the table, and it just basically essentially cooks and kills the tumor. This can be used as a primary treatment, so for some tumors that can't be removed, or tumors that are just best treated with radiation because of their location, or it can be used as a salvage technique, or to kill cells that might have been left behind after surgery. This is kind of just a quick example of how this process works. There's two broad ways to kind of immobilize the head during these procedures. They can form, I'm sure some of our patients are familiar with a mask. It's a plastic mold that kind of keeps the head rigidly or sort of semi-rigidly fixed while the radiation is occurring. You obviously don't want the head moving around because that's what's guiding where that radiation is going. The other way of doing it is something called a frame. So down there on the right-hand side there, you see the patient's head's been fixed inside of a rigid frame. That's where we use small pins, similar to ones we use in surgery during a craniotomy, to rigidly affix the patient's head to the radiation machine so that it can't move at all. This is the way we generally do it with something called gamma knife radiosurgery at Jewish Hospital, and this allows for those beams to be very precise within millimeters of precision, so that we can target things that are very close to critical structures like the brainstem or the optic nerves, and without having that radiation damage those structures, because we can be confident that it's very, very precise. And this is just a picture of how that looks in the actual treatment. The side effects of radiation could potentially most commonly include fatigue. I would say that's probably the most common thing I see. However, if the tumor is close to the edge of the skull and close to the skin, you can get things like hair loss or damage to the skin itself. There can be associated brain swelling because the tumor is injured and it starts to die, and that death process or necrosis of the tumor can cause the brain around it to swell and be unhappy. And then you can also, over time, if the radiation injures cells around the tumor that was treated, could lead to development of a secondary tumor. That's a very, very uncommon complication, but is definitely something that has been reported and we do see. Chemotherapy options, this is more specifically related to GBM. The most common chemotherapy we use in GBM is something called Temodar or temozolomide. Excuse me, this medication is a methylation agent. So what it does is it damages the DNA inside those tumor cells so that they die instead of creating more tumor cells, essentially. It's been the one medication, along with concurrent radiation, that's been shown through something called the Stoop protocol, which is what we use basically as our standard of care for the treatment of gliomas and GBM. The patient takes Temodar by mouth concurrently as they're undergoing their radiation treatment, which usually lasts between approximately 6 weeks. When you do that at the same time, the survival from that combination has been really the best step forward in the treatment of malignant brain cancer over the last 30 years. Although, much to our own dismay, it's a little bit of a modest benefit. I mean, it's we are doubling the survival rate, but we're still looking at a condition that is often or can be terminal. Avastin is another medication that we use in the treatment of gliomas or radiation-induced injury to the brain. This is a medication that has a lot to do with how the blood vessels form around these tumors or in the tumors. These tumors can actually form their own blood vessels to draw their own blood supply. So this medication takes advantage of that, kind of damaging that blood supply so that the tumor doesn't have what it needs to grow. It can also be used in radiation treatment where there's a lot of swelling related to the radiation. Lastly, I was going to talk about some of the biomarkers that you may see, especially glioma patients. They see these on their path reports and they often ask what they are. Biomarkers are really anything that can be used as a marker of a disease state. And the reason that we look at these is they can be prognostic and letting us tell the patient how they might do on certain treatment regimens. They can be predictive with regards to outcome or survival. And they can also be diagnostic, meaning that if certain biomarkers are present, then we know what type of tumor or subtype of tumor we're dealing with. The GBM biomarkers that are the most common are something called an MGMT, methylation status. So this is something that is somewhat relevant to the treatment. So that drug that we were talking about, temozolomide or Temodar, actually acts as a methylator, right? So if this methylation status is positive, it means that the tumor cell has a reduced ability to compensate for what that drug is doing to it to try to kill it, right? So it has a reduced ability to repair itself in response to the chemotherapy. So it's actually good if the patient's tumor has that as a positive marker, because that means when we give them the Temodar that those tumor cells are going to die, hopefully more effectively than if they didn't have that present. 1p19q deletion is something we use mostly as a diagnostic marker for oligodendroglioma, which is a subtype of glioma, but it can oftentimes is more favorable. So instead of coming from a glial cell, it comes from an oligodendrocyte, which is another support cell of the brain. They're all still under the broad category of glioma. IDH1 mutations are that's an enzyme in the Krebs cycle, but also when that is mutated, we know that those patients, we've done a lot of studies that show that if they have a mutation of that IDH1, then the tumor cell is more susceptible to radiation and chemotherapy, so those patients do better. EGFR, so these are kind of more specifically what we were just talking about. And so MGM promoter methylation, which means that it's positive, actually improves the 2-year survival rate from approximately 13% to 46%. So that's a really significant difference. It doesn't always necessarily affect how we treat the patient. Most of these patients will undergo STU protocol, including radiation and Temodar, even if they don't have the MGMT methylation mutation. But we know we can talk to the patient about, and it gives them a lot of information about prognosis to have that information. This is 1p19q, which we talked about is most specific to the oligodendrocyte diagnosis. When it's co-deleted, it usually means you have an oligodendrocyte, which means that your survival is going to be much better than things like an astrocytoma. So that's why that's important. And then these are the IDH1, IDH2 enzymes, as we just talked about. If they're positive in something like a glioma, then the survival is significantly improved because the tumor responds much better to the treatment. EGFR is just another biomarker that we've studied in glioma. These mutations actually are related to how the proliferation and the invasion and the new formation of blood vessels within the tumor. If this marker is positive, it's actually a negative sign because that means the tumor is very aggressive in recruiting its own blood supply and becoming aggressive and becoming more malignant. And that's something that Avastin targets. Lastly, these are some things that are just really more just kind of coming into the field of glioma. We've classically thought about glioma as one big thing. So, glioblastoma probably encompasses many subtypes of glioma tumors. And we've kind of thrown all those tumors into one big basket. And then we don't understand why some patients may do very well and some patients do poorly. It's probably because those tumors have different genetic profiles. They're not really the same, at least genetically speaking, the same type of tumor, because they're responding to our treatments differently. They're behaving differently. Some of them are more aggressive, or some of them are behaving more benign. And it's come to our attention that we should probably start to subcategorize those patients so that we can study them, and that we're not giving up on certain treatments because we are mixing all those patients together into one group. So really all this that we've talked about tonight kind of comes together in something we call our multidisciplinary tumor board. So we meet once a week, every week, to talk about all of our patients that have newly diagnosed or tumors that we've been following, and we want to put all our heads together and get a consensus opinion. So every week we meet with other neurosurgeons, medical oncologists, neuro-oncologists, our specialized neuroradiologists, our pathologists, physicians assistants, our nurse navigators and coordinators that help us with our brain tumor patients, and the radiation doctors, so that we can all in one room go through someone's scans, talk about their history, talk about the treatment that's already been delivered, and give them a really a tailored and customized plan for what we think would be the best possible treatment. And so you're getting essentially 6 or 7 opinions all in one visit that the patient doesn't even have to attend, and then the surgeon is being able to go back to that patient and relay that recommendation, and saves that patient from having to go to multiple visits and allows them access to multiple doctors. And we found that this multidisciplinary approach for really any type of tumor is the best approach, because we all bring our own special expertise. So at this time, thank you guys for listening and spending some time with us tonight to learn about brain tumors. I'd like to open it up for some questions if we have any from the audience.
Great, thank you, Dr. DiNapoli. That was wonderful. Yes, we do indeed have questions, and as I read them and they're answered, please feel free to continue to submit your questions. We have a good amount of time left. Okay. Cervical medullary lesions, are they common, or is there any new treatments or mapping of these lesions?
Depends on what kind of cervical medullary tumor we're speaking of, I guess. That's kind of an anatomic description. So cervical medullary refers to the area of the brain where the brainstem kind of meets the upper cervical spinal cord. So that's kind of right around what we call the foramen magnum. So our spinal cord comes through our cervical spine and joins with the brainstem, which is the base part of our brain. It's a very important area because that's mostly responsible for a lot of the critical functions of our body. So cervical medullary is kind of that junction between our cervical spinal cord and our brainstem. That could include things like glioma within the spinal cord itself, ependymoma, or it could also include things that are outside the spinal cord, like a foramen magnum and angioma. So I guess that it really depends on the pathology that we're dealing with in that area.
Okay, great. In January, I had a sudden new onset headaches and have been experiencing chronic headaches since. I'm seeing a headache specialist. He has ordered many brain scans, including CTA with contrast and CT, MRI, MRA without contrast. No sign of any tumors on these scans. A week or two ago, I was in the ER with TIA-like symptoms, and I continue to have leg weakness. I had trouble with toe to heel walking on neuro exam. What is the chance that I might have an undetected tumor?
Certainly I think if you've had MRI scans that have been interpreted both by radiology and a neurologist, and they've reassured you that they don't see anything, that's a very reassuring sign, right? So if the tumor were big enough or prominent enough to start causing weakness or problems, you would typically see that on the MRI. So that I would let that certainly reassure you. That's not to say that that's 100% not there, but it's a pretty good chance that is negative. There are a lot of other things that can cause these types of neurologic problems, and it really depends upon your neurologic exam where the weakness is. But it can include other things that are inflammatory. Things like MS could also be a possibility, or it could be something peripheral within the muscle or the nerve in the leg itself, or even in the spinal canal. So there's lots of things that those things could be. Luckily, headaches and migraines and those kinds of symptoms are more commonly not a tumor than they are actually a tumor. So that's a common, obviously, anxiety and fear people have when they start having new onset headaches. But the odds are in your favor that if you're having new headaches, typically speaking, brain tumors within the general population are actually a very rare disease.
Okay. I'm a 3-time ruptured brain aneurysm survivor and have been exposed to lots of radiation to the brain through the years, CTs, angiograms. Do I have an increased risk of getting brain cancer as a result?
Our data would suggest that there may be a slightly increased risk. It would obviously depend on how much radiation has actually been delivered. But even then, the risk, in general terms, the incidence is going to be still pretty low. So it's not something that I would necessarily worry about, but it is something that could be surveilled using an MRI like every so many years, which they're probably doing to follow the aneurysms anyways. And hopefully if something were to develop, they would be catching it early. Meningiomas are one of the things that can occur after someone's been exposed to radiation. Luckily, a lot of those are typically benign. It is maybe a slightly increased risk, but it's not something that I'd be overly concerned with.
I'm interested in size. What is the largest tumor you can remove safely?
Well, we remove a lot of, I mean, it varies, right? Things like vestibular schwannomas or acoustic neuromas, we go in for surgery and those tumors are relatively speaking very small, right? They're just in a very precise and difficult location, right? Those tumors are, a large vestibular schwannoma might be 2 centimeters, 2.5 centimeters, right? And because it's pushing on the brainstem and it's displacing the facial nerve and other nerves around that area, blood vessels. So it's in it's in the wrong spot. But, in a different location like the frontal lobe, we have tumors like olfactory groove meningiomas that can be the size of softballs before they even become symptomatic. I think the largest one I removed was almost 11 centimeters in size, which took up the entire, basically, forehead inside the head. So it just, it does vary on location mostly. I mean, if these tumors grow in areas of the brain like we talked about that are silent, the tumors can get very large before patients really say, man, something's wrong, something's going on here. But if they grow in areas that are near the brainstem or near cranial nerves where it's very tight space and there's not a lot of extra room, very small tumors can be very consequential. So I wouldn't say necessarily that the size of the tumor limits our ability to remove it. Oftentimes the bigger tumors can be easier to remove because they've already created a lot of space to get in there and take them out. They're sitting right there because they're so massive that the brain has been pushed away.
Okay. How would you identify what type of tumor it is?
So that starts really typically with the MRI. So, we look at your MRI scan. That gives us a lot of very good and detailed information. Looking at multiple different sequences on an MRI, you can often ascertain at least a pretty highly educated guess as to what we're dealing with. A lot of these tumors have very stereotypical patterns of growth, locations where they tend to occur. And those give a lot of clues as to what it is. The three things that we mentioned at the beginning of the talk being the most common, meningiomas are outside the brain, right? So that's one thing. We're looking, the tumor is occurring inside the brain or outside the brain, right? Meningiomas occur, generally speaking, outside the brain. So that puts those tumors into a separate category. And then there's a list of tumors there that occur in that space. And then we kind of look at the scans and say, well, this looks most like a meningioma. For tumors that occur inside the brain, gliomas are one of the more common, right? So we look at a sequence of scans and that gives us a clue. The next step then is deciding if the patient needs to have that tumor removed. And if they do, then obviously the pathology that we obtain from surgery when we take the tumor out gives us a final answer, right? We send that tumor off, they cut it up, they look at the cells and they tell us exactly what it is. So that'll give us our definitive diagnosis. If we choose to follow a patient over time with MRI scans, we're not really getting tissue in that regard, right? So if you have a benign tumor like a vestibular schwannoma, it's very small, you're doing well, the tumor is not growing, we might opt to follow that for years before we do anything, right? And really in that case, we're just using our own intuition and what we see on the MRI that this looks very much consistent with the vestibular schwannoma, and there are very few other things it could be. We generally start that process out with doing MRIs pretty frequently so that we can reassure ourselves, okay, for the first 4 months, the tumor's been identical. So that rules out pretty much all types of cancer, right? Because no cancer is going to sit there for 6 months and not grow. So that gives us reassurance. And then the next scan, we go to 6 months, and then we might go to a year. And then we do it every year for a while until we just know that the tumor is benign and it's not doing anything. And then we might even space it out even further.
Okay. How do you decide if a person will receive chemo or any other treatment?
So that, again, is based primarily on your diagnosis, right? So there are basically recommendations from our governing bodies that tell us, once you have that diagnosis from your pathology that is given to us, your tumor is classified and it's put into a diagnostic category, and that diagnostic category then dictates, what the treatment for that type of tumor would typically be, right? So some benign tumors can be removed and then that's it, right? So if a meningioma is there, we cut it all the way out, including the area that it's attached to, and there's nothing left behind. Oftentimes that tumor can be considered cured. But then if that meningioma is an aggressive meningioma, like a grade 3 meningioma, then that may require radiation or maybe even require chemotherapy if it comes back. So I think that those treatment algorithms are really dependent upon, most specifically, the type of tumor that you have.
Okay. Do you recommend patients seeking out clinical trials for treating brain tumors on their own? Where are the best places to find them?
Yeah, clinical trials can be difficult. I find navigating that to be a little bit murky, especially for patients that don't have the knowledge to necessarily distinguish between what might be in their best interest. So, yeah, I mean, I always encourage my patients to seek second opinions if that's what they are looking for. And I think getting as many people involved is never a bad idea, because you uncover things that might give you an option and provide some diagnostic benefit, or some therapeutic benefit rather. But we try to help our patients as much as we can. We have a nurse navigator who's very educated and skilled and can work with the patient to really seek out what's in their best interest and filter those very complex descriptions and kind of tell them what they might at least look into. Our neuro-oncology partners also help us a lot with that process. So they have connections throughout the country, and I trained at MD Anderson, so we try to use those connections and colleagues that we have to really just do whatever we can for the patient to get them the best possible treatment for their specific type of tumor. And if it's a rare tumor, they may have to travel to a place like that if they want to be involved in research, because some of these tumors are just not that common. We are also working to open up as many clinical trials here in Cincinnati with Mayfield to provide that next level care here in Cincinnati without the patient having to leave.
Okay, great. So on that note, as a family member, what is the best way to support my loved one with a brain tumor?
Yeah, I mean, I think it's a good question. I think we definitely have a lot of good research that shows a wide network of support, both from family and from friends, for these brain tumor patients is extremely important. They need a lot of support. They need, some of these tumors can cause neurologic problems that they struggle with for a period of time, and that support network is critical to their success, because it gives them hope, it gives them something to focus on, it gets them through the treatment. So I think as a family member, I mean, just being as supportive and understanding as you can be to, provide that inspiration, provide that hope, and to do the things that they need, that they need support with. I mean, it's difficult to even sometimes provide some of the basic functions of daily living. So having a supportive family really just allows these patients to get through the treatment effectively and optimize their outcome, right? Because having a healthy diet, being encouraged to exercise, take care of yourself, all those things are important.
Okay, great. How much radiation exposure do people get with security checks at the airport?
Oh, very minimal amounts of radiation, sometimes none. So that's not something I would be too worried about as far as brain tumors are concerned. As I said earlier in the talk, they have done some studies on the small amounts of radiation emitted by cell phones, some pretty good studies in Europe, and the incidence of brain cancer in people that use cell phones more versus those who use cell phones less didn't seem to make a difference. So those small amounts of radiation don't, at least in what we've seen so far, seem to make a difference.
Okay, great. I think we have time for about one more question. How about we end on an optimistic note? Where will the next big advancement in treating brain tumors come from?
Well, I hope Mayfield, but we'll see. I think obviously we always look to clinical trials and to evidence-based medicine for those advances. I think that's where it typically comes from, and it's foundations like the Mayfield Education Research Foundation that try to drive that activity, right? We want to put research dollars and philanthropic dollars towards the science and the clinical trials that need to occur in order to test new theories and to advance, our treatments. And that's generally where our advancements come from. Oftentimes, sometimes we do get a great leap forward in treatment, but oftentimes it's just the slow development of new technology and new ways of using that technology that eventually provides a benefit to our patients. And we need to make sure we turn all those stones over and do everything we can to get that, to advance that goal.
Great, thanks so much. Okay, I think this will wrap up our Q&A period. Again, this webinar has been recorded and will post on our website shortly. We hope you enjoyed tonight's presentation. If you enjoyed this evening's presentation, please register for our next program on May 19th, where we will learn from Dr. George Manuel the latest developments in deep brain stimulation for Parkinson's. You may register for the Brain Talks program at any time and view our past presentations on our website, mayfieldfoundation.org. For more information about the Spine Talks, Brain Talks, or the work of the Mayfield Foundation, please visit mayfieldfoundation.org. And again, I'd like to thank everyone for joining us this evening. Thank you again, Dr. DiNapoli, and we hope you have a nice evening.
Thank you, guys. Thanks for your time.
Thanks.